It's indeed a pleasure for me to share with you ideas about genetics and genomics in a simple way that may appeal to a wide-ranging audience, so that you would find out, or you would get some ideas as to how genes could affect your health and well-being. So that is the reason behind the title of this talk, Your Genes, Your Health. In this talk, I would like to use a few examples which people would be familiar with about genetics and genomics, as well as, of course, go beyond and tell you more futuristic things as well. I'd like to keep it simple so that you do not have to know high-flown genetics to understand the concepts that I'm going to talk to you this evening. I would like to begin by congratulating the library on its centenary. And of course, when you talk of centenaries and anniversaries, the Faculty of Medicine of the University of Colombo, of which I am the Dean, celebrated our 150th anniversary last year. So it is in this, what we would say, the anniversary time that we are all meeting. The Human Genetics Unit in the faculty where I do all our research work was founded in 1983, and it is one of the oldest such centers in the Asian region. And it was founded in 1983 by my predecessor, Professor Rohan Jayasekara, who is probably can be considered the father of genetics and genomics in our country. And it is due to his efforts that genetics and genomics took root in Sri Lanka. And I'm, as the current chair and the director of that unit as well, I'm taking that legacy forward. Your Genes, Your Health was the title of this talk. So all of us look at ourselves and our families and beyond when we talk of genetics and genomics. And we, the medical community, when we talk of genetics, like to draw pedigrees and illustrate on our pedigrees the health status of individuals. So we draw pedigrees using squares to depict males, circles to depict females, and draw lines joining the grandparents to parents to children. And of course, we can have further extended pedigrees. But when we draw these pedigrees and draw on them people affected with any condition. So for example, as a doctor, when people come to me and consult me, I look into their family histories and draw pedigrees. And when I draw that and I indicate on a pedigree a person affected with any condition, generally the pedigree ends up looking like this. There's just one person affected with any condition, or the condition that the consultation is being made on. It could be a rare condition, which we know traditionally to be a genetic disorder, meaning, so therefore this would be the first person affected with that condition. But however, more commonly, what we come across in families where just one person affected is found are common disorders. It could be diabetes, high blood pressure, some form of cancer, stroke, or anything. When we see pedigrees like this, we don't think too much of genes. We think of them, or we call them, the sporadic occurrence of the condition. Unless this was a condition which we know traditional to be a genetic disorder, we will not be talking of strong genetic influences causing this illness. There are many families with one-off person with diabetes or high blood pressure or cancer or any other condition. We get a little bit more excited when we see pedigrees like this. There is more than one person affected with that condition. We call it the familial occurrence of that condition. There is, in this kind of condition, an underlying genetic predisposition. The expression of it has been brought on by junk foods, bad habits, smoking, alcohol, and so on. So various other environmental influences acting on our genetic predisposition. So when I talk to medical students, I always tell them, when I was a medical student in the 1990s, and I can distinctly remember the first day I walked into my medical appointment, the first medical appointment, there was just one patient with diabetes in that ward. And all of us, stumbled around that patient to learn about diabetes. But today, if we go into a medical ward in the National Hospital of Sri Lanka in Colombo, which is our premier teaching hospital, we find that almost every bed is occupied by a patient with diabetes. So what changed over the past 30 years? Our genes didn't change, our genetics didn't change. It was our environment which changed. So we always had this underlying genetic predisposition, but the introduction of bad food habits, junk food, fast food, all kinds of fizzy drinks, and the environmental pollution that we see all around brought on the expression of that underlying genetic predisposition. We know some amount of details about that genetic predisposition. However, more research have to be done to identify and elaborate on that genetic predisposition. The third type of families we see are families like this, where there are many people in several generations affected with a known genetic condition. We will see a pattern of inheritance, usually autosomal dominant pattern of inheritance. We will see young people in that family affected with that condition. If it was, for example, a condition like cancer, you will see that if it was, let's say, breast cancer, both breasts are affected, not one breast. If it was a cancer affecting the kidneys, both kidneys are affected, just not one kidney. And then you will find a pattern of cancers that we know are part of what we call inherited cancer syndrome. So similarly, there are such patterns that we see even with conditions like diabetes, high blood pressure, heart disease, and so on, where we know that there is a definite underlying genetic contribution that is happening. And then these are the families where we traditionally have been focusing on in genetics and making diagnoses and helping them overcome their condition or get the best treatment and prevent death and disability. These rare hereditary conditions are caused by what we call low frequency genetic variants in a single gene. So there are lots of these conditions out there. In fact, we say 1 in 10 people in any community, any country is affected by one of these rare disorders. So if you extrapolate that to our population, knowing that there are 20 million people here, we will have 2 million people in our country affected with these so-called rare hereditary disorders. And when we actually look into them, we find that that is the case. Common sporadic conditions and the familial disorders are caused by what we call low penetrant, high frequency genetic variants in more than one gene. So that is why, for example, we find a situation where now we have lots of people affected with conditions like diabetes. Lots of people have these genetic variants. What we mean by penetration or concept of penetrance in the likelihood of that genetic predisposition being expressed. In the past, it didn't express because we had good food, the environment was good, and so on. But with the bad habits, smoking, alcohol, all that environmental effects, now we are expressing those bad traits that we have. So if you look at us, our genetic composition, we, as you know, have 46 chromosomes. We get 23 chromosomes from our father, 23 from our mother. And what we find in these chromosomes is a long strand of DNA, which is organized into individual genes. So we have roughly about 25,000 genes in our genome, in the 46 chromosomes that we have. And when we look at the chromosome level as well as the DNA or the gene level, we have what we call inherited genetic variations. Now, those inherited genetic variations, some of them are pathogenic, meaning they cause disease. Some of them are non-pathogenic, meaning they won't cause any disease. There are, of course, also in between areas. The non-pathogenic ones we call definitely, we give the name benign. So in between the pathogenic and benign, we have gray areas as well. And because certain more and more genetic information is now being elicited, we find that there are a lot of genetic variants, of which we classify them as variants of unknown significance. And then we try to work out what they mean through various genetic research. Now, in addition to the inherited genetic variations that we have, during our lifetime in our cells, we also develop new genetic variants, which we call acquired genetic variants. So due to the effects of these various things like radiation and so on, we can acquire genetic variations. Even in certain infections lead us to acquire genetic variations, and they may become pathogenic and cause illnesses. The inherited variants are also called germline genetic variants, and the acquired variants are called somatic variants. So you may hear about those words as well. There are so different types of tests that we can use to test for these variants. To look at genetic variants at chromosome level, we have techniques like chromosome culture and karyotyping, fluorescence in situ hybridization, where we color the chromosomes and look at them, and also newer techniques like microarray. At gene level, we will be using a plethora of tests. There are PCR tests, real-time PCR tests. There are the conventional Sanger sequencing, and of course, the newer next generation sequencing. We have all these technologies in our country, and in the human genetics unit of our faculty, we have all the genetic technologies that are required to do any genetic test. So who will benefit from genetics and genomics, as it were? So any person with a concern about a condition running in that family should undergo genetic evaluation. That is the kind of mantra that we used to use in the past. But today, genetics and genomics is used much more widely in practice. Anyone may benefit from genetics and genomics, and towards the end of my talk, I will illustrate that. But to begin with, let me take you through the life cycle, as it were. Genetics and genomics is applicable across the life cycle. So as a clinical geneticist, one of the fascinating things that attracted me to the field was the fact that I will be working with all kinds of people, not just children or adults or a specific group of disorders, but with people across the life cycle. Genetics and genomics become relevant to people before marriage. So we have people coming to us seeking our help because they are now planning to get married. There are different groups of people who come to us, and two groups which are of particular concern are the ones who are worried because they are consanguineous, meaning they are relatives. So it could be first cousins or other forms of relatives, and they worry whether they would have a particular illness affecting children in the future. There are sometimes certain ethnic groups as well amongst us who intermarry a lot, and they also seek our help to see whether how to reduce that risk, or to how to identify that risk. Then, of course, there are couples coming from families who have a history of a known genetic condition, and they would like to know what their risk is and how they can prevent the occurrence of that condition once they get married. So today we have the technology in the form of analyzing all the genes in a person. We can sequence the entire genome of a person and make predictions, identify genetic risks, and help these couples. And we do that. We do that regularly. Then, of course, once you identify the risk, people would ask, okay, why do you identify if you cannot do anything? It's not that world anymore. We can do a lot to help these couples have normal children through assisted reproductive technologies without the need for going down the route of aborting babies. There is the way of identifying genetic risk, looking at creating embryos which do not have those bad genetic predispositions, and creating embryos that are healthy and having healthy babies. So you can help such couples. So that is why we embark on these technologies to help them. So gone are the days if you really start early at the stage of before getting married, you can really plan and have good babies without worrying about abortions and so on. Then, of course, we have married couples who obviously end up with subfertility sometimes and recurrent abortions. And we can help them too. And this is an interesting group of people because in the absence of being directed for genetic evaluation, they unfortunately go round and round. And I thought I will illustrate to you some cases, because I'm sure amongst the audience today are professional couples who are having children late in their life and are aiming to have healthy babies, and they do experience subfertility and recurrent loss. That is one group that we deal with most of the time, and they sometimes are delayed in genetic evaluation. So here is one example. Here is this lady who has what we call a balanced translocation. So if you look at chromosome 21, unlike all other chromosomes where she has 2 chromosomes, in chromosome 21, she only has one chromosome. So she only has one chromosome 21. And the other one is sitting on chromosome 14. So this is called a balanced translocation. And this kind of balanced translocation carriers would experience recurrent pregnancy losses, and sometimes, of course, they run the risk of producing a baby with an abnormality. In this case, a baby with Down syndrome. So we need to prevent them. So the fact that somebody is experiencing delay in pregnancy or experiencing recurrent pregnancy losses may be because of balanced translocation like this. Here is another balanced translocation. This time the translocation is between chromosome 3 and it's between chromosome 3 and chromosome 15. So 3 and 15. This person is perfectly normal because a piece has got dislodged from there and attached here. And then, of course, another piece from here has got attached there. So that is what we call a balanced translocation. But when they go to have children, there will be recurrent pregnancy losses and so on. So that's another example. A third example is this. Here is what we call an inversion. And there are lots of people with this inversion in chromosome 9 out there. So when I say lots, 1 in 500 people out there in the community. And they would also experience recurrent pregnancy losses or subfertility. And in this case of inversions, most of the time subfertility, because they will not get pregnant and very rarely get pregnant. So therefore, any couples who are experiencing subfertility and recurrent pregnancy losses should have genetic evaluation and then be properly guided to have a healthy children. Subfertility and recurrent pregnancy loss are distressing to couples, but however, it is the nature's way of protecting them from having a baby with an abnormality. So we need to take that as a warning before we go into doing assisted reproductive technologies to try to overcome those natural barriers and help them, because once you use artificial means of overcoming the natural barriers, then you may end up with the good intention of helping, but with a bad outcome, and we don't want that to happen. Moving on from there to babies. Now babies come to us for various conditions. So there are thousands of conditions out there. And as I said, individually they are rare, but when you lump them together, they are common. The exciting thing about being a practitioner in the field of clinical genetics is that there are so many different people with conditions coming to see you. So there are the so-called dysmorphic syndromes, where there are physical and abnormalities. Then there are the single gene disorders, where there could be physical abnormalities, but there may not be. Then they may manifest in different other ways. Then, of course, there are the metabolic disorders group as well, which affect the metabolic condition group, metabolism in the body. And of course, those will not generally present with any abnormalities to begin with, but abnormalities may manifest later. These days, intellectual disability is becoming a major issue. There are some surveys done by the Ministry of Health showing 1 in 93 children have intellectual disability. And the good thing about it, if at all, is the fact that there are about more than 80 conditions which are rare, which have a treatment only if you diagnose them properly. And usual means of diagnosis is difficult, so therefore you need to take the genetic route. And then of this group of what we call the undiagnosed disorders. There are lots of undiagnosed disorders out there which really await diagnosis and genetics and genomics now is used increasingly around the world to diagnose these conditions, and we have used it even in our setting to diagnose these conditions and help people. We are a part of what is called Undiagnosed Disease Network International, which is a big global group of clinicians and researchers working on helping undiagnosed disorders, helping clinicians to get to the diagnosis of undiagnosed disorders. And you will be amazed when you look at this group, because there are, for example, I can tell you, we had a family with three children who were never diagnosed, and they are now not children anymore. I've followed them up for more than 15 years, and they are now in their 20s, late 20s, and using genetic technologies, the newer technologies on genome sequencing. After all these years, we arrived at the diagnosis in that family. And today, we are, with these technologies, we are able to reduce the so-called diagnostic odyssey in undiagnosed disorders. But again, to illustrate the importance of genetics, just going back to the basic of genetics, as if Down syndrome. The Down syndrome that we see out there as one syndrome genetically is not one, because underlying that Down syndrome are different genetic mechanisms, and getting to a genetic diagnosis is so very important, because it is only when we do that that we can help these families have healthier children in their future pregnancies, or also prevent the occurrence of more children with Down syndrome in these families. You will be amazed when I tell you that I've come across a family in our country, our setting, where there were 5 children with Down syndrome. And that illustrates a complete failure on the part of the system to help them. And those extreme examples are there, but by and large today, the situation is improving, and we are able to help such families. The initiation, of course, has to happen at the level of the family, because sometimes, especially in rural areas, the knowledge and the motivation to seek genetic help is not there. And so us, the privileged community of the University of Colombo, all of us coming from rural areas, I think have an opportunity to help our rural communities by disseminating knowledge about genetics and genomics to the lay people in those parts. Of course, as I said, today in the realm of undiagnosed disorders, what is helping us to reduce the diagnostic odyssey is the genome or exome sequencing, where we can test all genes in one go. And that has been one of our focused areas. And one of my colleagues, Dr. Dineshani Hettiarachchi, has been working enormous, focused on this area. And she's produced a series of articles over the past few years, where we've described and discovered and helped families with these rare undiagnosed disorders. Moving on from those childhood years to the teenage years. Teenagers also have various disorders, and the group of disorders of sexual development and primary amenorrhea is an important one. This is an area where we have researched a lot and published, and I would invite you to look at those scientifically inclined, to look at our publications through a PubMed search. And all these conditions which were traditionally seen in textbooks as by medical students in the past, here in our community as well, even amongst us. So we have described all of those traditional, conventional genetic disorders that have been described, and they're all there amongst us. So the two main examples are Klinefelter syndrome, where there is an extra chromosome X in a male, and of course Turner syndrome, where there is only one X chromosome in a girl. But of course, these are the classic descriptions, but there are many variations of these. And for anyone who's interested in researching and going into these areas, please look at, do a PubMed search and look at our publications, and you would see the spectrum of these conditions that are found in our population. So, what we really need to do is, if those teenage boys and girls have issues related to their secondary sexual development, they should undergo genetic evaluation so that we can do the appropriate test and help them. And there is a lot that can be done for them to overcome, if not all, but some of the physical, mental, as well as clinical issues that they are facing. Now, moving on to the adult group, there are many conditions, but the adult onset neurological disorders and cancers are two areas that generate the largest number of clinical referrals for us. So the largest numbers of patients that we see come from neurological conditions such as ataxia and Huntington disease, as well as then, of course, now with the increased awareness about cancers in cancers. So let me illustrate to you how we help families with cancer. Generally, when the clinicians come across patients with cancer, they refer patients to us. So in this case, in this family, we have one person affected with breast cancer at the age of 40 being referred to us. When we'll go into the family history, this lady tells us that she had a sister who was quite very much older to her, at the age of 56, developed ovarian cancer and died. Her mother had breast cancer when she was 32 and died. And then she had something unusual. The grandmother, who had died a little late, of esophageal cancer. Now, in a conventional setting, the doctors amongst you who are here might wonder, what should we test? Are we looking at the BRCA1, BRCA2, or should we be looking at any other gene? So today, what we do is, we don't go and look at one gene at a time. We go and look at all the genes at once, so that immediately we can arrive at a diagnosis, and that is what we did in this family. So when we did the genetic, the entire exome and looked at all the genes, we found a pathogenic variant in the BRCA2 gene. Now, the moment you find that variant, now you can go back to this family. There are lots of people who do not have cancer. Then there will be the children of these people who have got affected, and so on. And we can go and help these. We can look for this genetic variant. If the variant is there, we can advise them on what kind of lifestyle changes they have to do to reduce their risks, what kind of medical interventions that they should undergo not to develop the condition, and so on. And of course, for those who are not carrying the genetic variant, mental relief that they would not have to undergo the agony that other relatives in the family had to undergo. So we have families, large families. This case is just an illustration Sometimes we have families with 20, 30 people affected with cancer, and many more at risk when we draw the entire pedigree. And we are in a position now to test them and help them. And so in this day and age, when there are effective interventions available to prevent the occurrence of cancer, there should be no reason why any family which has cancer running in that family should have more newer people developing cancer. Everybody's risk should be identified and those people prevented from developing cancer. Now, to do that, what we do is we look at this so-called inherited genome. But as I said, it's not only the inherited genome, but the acquired genetic changes that we have. And cancer is one area where those acquired genetic changes are important to make decisions about treatment. What treatment works best for for a particular cancer is made. That treatment decision is made by looking at acquired genetic changes in the tumor tissue. And you may have heard of this word precision medicine. Precision medicine is practiced in the context of, mainly practiced in the context of cancer, where you are looking at acquired genetic changes in the tumor tissue to make decisions about which drug is best to treat that condition. So today, in our setting too, we do this kind of tests to identify which drug would work for patients and which drug will not work for patients. And with that, we are able to help these families or help the affected patients get the best treatment. So that is one example of where which would be useful, I believe, for many people in the community out there. Moving on to old age. Now, there are lots of conditions that affect people in their old age, and dementia is one of those conditions which we are increasingly seeing. So much so that 1 in 3 people either have dementia or if you take 3 people, they would either have dementia. One of those, old age, they would either develop dementia. Another one person may develop, Parkinson's disease and the variants of that. And another, the rest of the 1/3 would develop all other kind of conditions. So dementia also has a very important hereditary component, and the risks of the genetic risks of conditions like Alzheimer's disease have been worked out, and it is possible and for us to test people and tell them about their risk so that they could take action to prevent or reduce that risk through various interventions. Some of them simple interventions like lifestyle modifications, and others, of course, may require some medical interventions as well. So, ladies and gentlemen, I've taken you through that life cycle, and so the bottom line is that if anyone is concerned about a condition running in their family, they should undergo a genetic evaluation. And to do that, you don't need to come to a specialist. You should talk about that with your family physician. After all, family physician is the one who knows about your family, the illnesses that affected all of you, your various generations in your family, if you're close to a family physician. So that is where the conversation has to start. The conversation has to start with the family physician. Okay, so that is the message. Now, when we talk about genetic disorders, one common question that people ask me is there treatment? There is treatment. There is treatment coming now for many conditions. And so it's not the past anymore. or sometimes curative treatments are coming. Sometimes there is effective treatment to delay the onset of bad events that are associated with those genetic conditions. So therefore, seeking treatment is important. There are lots of people who give up when they are faced with genetic conditions. And my message is, don't give up. It is your own, perseverance that actually motivates the doctors also to do the best for people who are affected with genetic conditions. So if you have anyone in your family or anybody known to you who has just given up because they have been told that they have a genetic disorder, motivate them to take leadership for their own health. And there are lots of people who have lived far beyond the lifespan that the doctors have given them, just because they were motivated and they took the initiative, or they themselves who are affected took the initiative, or their families took the initiative to help the people suffering from that condition. So we went through the life cycle. And today, one of the questions that patients as well as others ask me is, do you really need to wait till you are afflicted with a bad genetic event to find out your genetic risk? The answer is no. We are able to sequence the entire genome of a person. And when you sequence, you can make predictions. So patients come to us sometimes asking us, telling us that they would like to get a sequence. Not patients, people who really sometimes even do not have any illness. And we can sequence them. And when we sequence them, we look at genes which have genetic variants, which if those genes have those variants, the people are likely to develop serious medical conditions in the future. And then we can advise them of their risk. We can advise them on how to overcome those risks. So today we've got genetics, genomics, as well as the informatics working together. We need informatics to handle the genetic data. So if, for example, I were to sequence one of you and look at your whole genome, we would generate hundreds of gigabytes of data. And that data can only be handled through information technology using informatics. So we have and when we do that, we come to a totally different paradigm of what we now are coining as digital health. Digital health is the convergence of genetics, genomics, as well as the newer digital technologies to help people. And so in the past, we had the disease, diagnosis, management, then prediction, prognostication, and prevention models. But today, that model is changing. We can sequence a person at birth even and look at the risk-made predictions and put the prevention at the forefront and make early diagnosis and institute management strategies. So disease is reduced as far as disease, death, and disability is reduced as far as possible. So in the past, genetics was used to help the rare hereditary disorders, but today genetics is used more commonly in the sphere of common sporadic and familial disorders, and the contribution for that group is becoming more and more. And that is also dependent on generation of newer knowledge. Because this group are not going to have one genetic risk or genetic predisposition in one gene. Their genetic predisposition is going to be spread out. So coming back to that example that I gave you at the beginning, where I said, in the past, as a medical student, when I went to the ward, I saw only one patient in my ward in the first day with diabetes, and today we have all these patients. The reason for that is because this group, the large group of sporadic and the familial group, what's happening to them is we are identifying their underlying genetic predisposition. So, for example, if you take diabetes, we've got large numbers of people having these little risks of developing diabetes. This odds ratio and the confidence interval, if you have this particular variant of developing diabetes. And then, so if you have 2 or 3 of these risks and the environment acts on it, then one day you will end up developing the condition. And that is where, that is why these common conditions are becoming commoner and commoner now. Another way of illustrating that would be this diagram here. This is applicable to all of us. On the vertical axis, we have the disease state. In the horizontal axis, we have the time since birth. So 0 is when all of us who were born healthy were born. 0 time, 0 disease. But as time was, in our early days, we were in homeostasis. We were, we had our mother's milk. We were drinking our mother's milk, which was a natural, which is a nature as its best. We were healthy. But as time went by, and then we, started having the normal foods, things started changing. Then when you become teenagers, bad habits, smoking, alcohol, fizzy drinks, and other things come about, the metabolic stressors start playing up. And after a while, what really happens in this group is that we start developing what we call the metabolic syndrome. And at that point, nutrition is not what we cannot, help us. We need to now move on to pharma. We need to start taking medication. And then that is the entire spectrum of what we call the complex disorders now. And so the pharma will now have to identify the different drug targets and intervene, and that's what why the big pharma industry is developing. But we could have done this simple thing. Our lifestyle in the past was dependent on this philosophy. We had the correct diet. But today, when diet is wrong, medicine is of no use. When the diet is correct, medicine is of no need. And that is the philosophy on which our civilizations grew on. And we really need to go back to that philosophy of, having good food, healthy food, getting away from the food that's grown on the fertilizer, artificial fertilizer, and so on. So that is where we are heading now. We are identifying what we call the entire spectrum of the exposures that we are having, and we are using the word exposome to characterize that. We are identifying our underlying genetic predisposition, and the future would be a combination of our traditional ways of intervening. I've in the past I have predicted emergence of what I call Eugenics as the future way of going forward. Before I wrap up, I would like to deal with 2 more issues. One, COVID. People ask us about COVID, is whether there is any underlying genetic predisposition in COVID. The answer is yes. That is why there are those who are not affected with COVID, large majority who are going around with asymptomatic carriers, because those are the ones who have the correct genes or correct genetic variants in their immune genes which protect them. Then, of course, those who have the defect, if you were to say, using layman's term, the not so bad genetic variants, they develop mild symptoms, and those who are really do not have those protections are the ones who go on to develop the severe disease and eventually die. So there is definitely underlying genetic predisposition. I will show you in down the line in a couple of slides the consortium that is working on identifying the underlying genetic predisposition. Now, for us, it is important to do work on identifying what that underlying genetic predisposition in the country is, or the genetic protection, if we have one. To illustrate that, I would like to use some data coming out of a research project that we did a few years ago. And that is this. We looked at all the genetic variants that were important in our population in collaboration with an international group. Which was led by myself and Liam Bram from the University of Singapore. And of course, then we've got Nilakshi Samaranayaka, our colleague from the Department of Parasitology, working with us and leading that group. And what I want to share with you is the importance of doing work in our population, because we are not we cannot generalize data, especially when it comes from genetic data. These 4 charts show genetic distances of different ethnic populations. This chart shows the so this is the genetic. These are genetic distances. So the first group is the Sri Lankan populations, Sinhalese, Tamils, and the Moors. Our genetic distances are not much. We are all together. We are genetically very close to each other, the Sinhalese and Tamils and the Moors. But when we compare ourselves, the genetic distances, these are what we call principal component analysis charts. When we compare it with the South Asian populations, Gujaratis, Punjabis, Bengalis, Sri Lankan Tamils in UK, Indian Tamils in UK, and the Indians in Singapore, we are also very similar. We are, as a South Asian group, very similar. When we compare ourselves, that in the Sri Lankan group, with the Singaporeans, Chinese, and the Malays, you find that there is distance emerging. So this is us. This is the Chinese and the Malays. And then when we compare all these with the last group, the white Western Europeans, CEU, we see they are all different. That is the white Western European. This is all the South Asians, and this is the Chinese and the Malays in Singapore. So what do we do in the field of medicine? We look at the British National Formulary. We look at the drug doses. We look at the side effect profiles, and we dose our patients, assuming that everything will work, and it doesn't work. So therefore, we need to generate data for our country when it not only comes to all the traditional disorders that we know of, but all the newer things also, like COVID. So so therefore, it is really important for us to do things like this, look at the host genetic contribution, not only conditions like COVID, but all other conditions as well. So ladies and gentlemen, during the past hour or so, I think I've taken you through a whole heap of stuff and shown you the multiple ways in which genetics and genomics play a role in our lives. We need to embrace genetics and genomics, because genetics and genomics is becoming center stage in medicine. It's not only playing a role in the way we practice medicine, but it's also informing us on the need to go back to the healthy lifestyle that we were traditionally accustomed to, because it's showing us that when we prevent by going back to healthy foods, healthy lifestyles, and healthy habits, that we prevent the emergence or the expression of our bad tendencies. And so therefore, genetic knowledge is essential for all of us, not only as doctors, but also as ordinary citizens of this country, because that's the way we can preserve our health and well-being. And as we all agree, health is wealth. So with that, ladies and gentlemen, thank you very much for your patient listening. I would be happy to answer any questions if you have. Thank you.
Yes, thank you, sir. Mr. Hamanan and Mrs. Manatunga, now over to you for a Q&A session. Mr. Hamanan?
Yes, thank you, Professor, and thank you, Madam. It was a wonderful presentation, Professor, on genome and their connection to the genetic disorders as well as pandemic kind of things. So I open the platform for the participants to throw your questions if you have, please do.
I can pick up the questions from the chat. I see a few questions from the chat. May I?
Yes, sir. Please.
Yeah. So the first question that I see is it possible to make modifications in genes responsible for hereditary conditions in germline cells in future clinical practice? The answer is technically it would be possible, but ethically it would be unacceptable, and therefore we will not embark on that. Okay. You may have heard recently of a very controversial case where a Chinese scientist did this, and he has been virtually banished by the entire scientific community as well as everyone else. So that is something that we would not ethically want to do. Prof. Ravitra is asking if our genes are different from Western and Chinese people. Will the COVID vaccines develop their work for us? Will the efficacy level be lower, different? So these are the things that we need to really look at. The immune response that we mount may be different. So therefore, we need to do studies in our population as we go on, along, maybe 3 months down the line, 6 months down the line, as to what level of immune response we have generated, and then of course also clinically follow up these patients and see how many of them actually develop COVID, how many of the people who have been vaccinated develop COVID, so that we know whether they are actually effective in our population. So that's a very important and good question. But I must also tell you, because there are lots of you in this in the webinar today, anecdotally, what my clinical colleagues are telling us, if you look at the patients in the wards now who have gone in from developing just the mild symptoms to going into high dependency units and the ICUs, they say that they don't see patients who have taken the first dose of COVID shield in high dependency units and ICUs. So that's a good sign, and that is also an indication that we should all strive to get vaccinated. Next question. Sir, can you explain the genetic basis used for development of COVID-19 vaccines? Well, I wouldn't try to embark on that. I'm not a vaccinologist to try to, answer that question. Sorry, I'm going to skip that question. Hopefully, in a future talk, the librarians would invite a vaccinologist to give a talk focusing on that area. Is there any bad effects from Wi-Fi or other signals on genes? Well, genetics, the genes can be affected by many things. Radiations, radio wave frequencies, even other viruses and bacteria and so on. So genes could be affected in multiple ways. But the good thing is this: we have repair mechanisms in our genome. So when the genes are, when we acquire genetic changes, our genetic repair mechanisms will go and correct them. And it is only when those repair mechanisms fail that we will acquire those genetic variations, and those will proliferate in our cells and cause various illnesses. So while there could be bad effects through all of these things, we also have the inherent resilience to overcome those or correct those defects. And it's only when we are unable to correct, we will develop the bad effects, or we are repeatedly exposed to those. And then that insult is repeatedly acting, that we will develop those effects. Okay. What are the indications for use of genetics for Ayurvedic physicians? Well, the obvious, answer to that is, I'm sure the Ayurvedic texts also describe the conditions which are caused by genetic disorders, and they will say, okay, these conditions are caused by genetic defects. So it could be, so you will have to be led by your texts, which say, like us, we are led by texts which say, okay, based on these conditions are caused by genetic disorders, therefore you need to do a genetic test or refer to a geneticist. So like that, I'm sure there are guidelines on your Ayurvedic texts as well. So, I mean, anecdotally, I can tell you, Ayurvedic physicians have cured genetic disorders for which there is no Western medicine. Recently, we published a paper of one of those conditions where there is no Western medicine, but the patient on their own went to an Ayurvedic physician, and the condition was cured. So there are lots of things both systems have to learn from. Okay. How many patients with cancer should be there in a family to suspect genetic predisposition? No, you can't go by the number, Dr. Anthony. You got to look at the family tree. And today, because of the fact that I told you, the fact that, more and more of the genetic predispositions are expressing because of environmental effects. Even the fact that somebody develops cancer at a young age, just one person, when I say young, before the age of 50, is good enough to initiate a cancer referral and cancer testing in that family. And that is the recommendation that is coming from Western countries. So they are seeing, the reason why that recommendation is coming is because we are seeing, even in the absence of a strong, family history, you find that there is that underlying genetic predisposition. And why? Why are we seeing that? We are seeing it because it's expressing now because of all the environmental influences. So there could be the first person now in a family expressing that predisposition, while there are lots of others also affected with it. Okay. Another question from Prof. Ajit Malasekara. With genome-wide association studies, what are the Pandora's box issues raised with detection of risk for particular diseases? Yes. So now, so what's really happening now is when we sequence patients for one condition, we find that there are the so-called incidental findings. So the other day we sequenced a patient because of a particular condition. I don't want to tell the condition to preserve anonymity. That was a condition associated with the skeletal system. But what we really found in that person was that that person had a genetic variant in a cancer predisposition gene. Now, what do we do with that? We know that with that genetic variant, that this person will develop cancer in the future. And in the information that we got, the clinical information that was sent to us, there was no information about cancer. So how did we deal with that condition? How did we deal with that information? So the patient came to us for counseling, and we counseled based on the information we found for the condition for which that patient was referred to us. And at that point, we told the patient, look, because now we have sequenced all of your genes, we can look at other things also. And is there anything in your family that you haven't told us, or you haven't told your doctors who referred you to us before? And the patient said, yes, my father died of cancer when he was in 30s. And is there anything else that, can you look at cancer? So, so we dealt with that issue. So we said, yes, we can look at it. So we gave another, appointment for the patient to come back to us. So we didn't break the news, as it were, at that point. While knowing it, we wanted to be empathetic to the patient, and the patient went back and came back to us. And at that point, the patient was ready because he had told us to look at cancer. We were also ready. We knew that the patient was coming mentally prepared even to receive bad news. And we broke the news and showed her the ways of how to go forward. So yes, when you sequence people with information, we are opening up a Pandora's box, but then we are able to deal with it because of the because now we are developing the protocols to deal with that kind of situation. Okay. Will any disease of like diabetes or gestational diabetic any syndrome to a child? Will any disease like diabetes or gestational diabetes bring any syndrome to a child? Yes. So some of these maternal conditions are associated with higher risk of various conditions to children. I don't want to generalize and start throwing up names here, but it is important for pregnant women who have various conditions to be counseled about the risks of different conditions. And of course, much more than that, the pregnant women who are undergoing under various medications have risks of children developing conditions because of the toxic effects of the medication that they are on. So it's very important for women who are on long-term medications before they get pregnant to receive proper counseling, proper advice from their doctors. You don't have to come to geneticists. The doctors know the adverse effects associated with the medication they are on, and then to be changed to other more safer medicines. And that has to happen. So any woman who is on long-term medication for any condition, before getting or planning to have a child, should have a discussion with their doctors about the need to change their medication prior to getting pregnant. There's no point doing that once they know they are pregnant, because the teratogenic effects are most severe during the first 2 weeks of the embryonic life. And the first 2 weeks of the embryonic life are passed by the time a lady knows that she's pregnant. So therefore, you have to plan that before trying to get pregnant. Why do some COVID patients develop long-term side effects and some don't? Well, again, these would be, associated with our genetic predispositions. So these are newer areas of research and knowledge that will emerge as we research into this, into the condition. Okay. If there is a hereditary condition for a disease, is it certain that we get the disease, or can we prevent the disease by other factors? Yes, you can prevent the disease by other factors. And that is the reason why we are, as I said, the future paradigm would be sequencing people, identifying their genetic predispositions, and taking action to prevent them developing the condition. Okay. I think I picked up all the questions in the chat box. Yeah.
Yes, sir. I think you have answered all the questions in the chat box. Can I ask a very simple general question? Mm-hmm. So if one generation is having a cancer, for example, breast cancer in a certain age, let's think in 60s. So how early the second generation should start screening for it? Because sometimes these information, they say that it comes 10 years earlier than the earlier generation, though. So how, sir, is there any age gap?
It's like this. Now, that's a good question. There are, let me illustrate you now. There are two ways of looking at it. Now, one way would be to say that earlier your predispositions, the better. So, so how early? I think what we generally do is we let the individual decide once they become adults. So the lawyers amongst us here would tell, you can make a decision after you are 18 years of age. So that's the age of consent in Sri Lanka. So we let people, individuals, because we practice the concept of autonomy, we don't want to push children to be tested for adult onset disorders and then be worrying for the rest of their, time or whatever. So we allow them to, allow people to become adults and then make informed, consent on their own and make a decision. So that is the general thing that we practice in our clinical practice, unless doing a test early before they become adults is important medically to start instituting preventive actions. Okay, so that is the principle that we would adopt. So, so what I say is, what I tell patients, families, parents, and so on is, if you have any concern about a condition running in the family, wait till your children become 18 and or older, and at that point, start having a conversation with them. But having said that, today I know the teenagers are, operating at a very high level of, knowledge. So, but then at that point, still, we wouldn't try to push them to for genetic testing unless it's really, really important for their own health. Okay.
Thank you, sir. And it means that it is very important that, as you said, sir, to take this information, this knowledge to the general public, because they have to take their decisions when they are adult, whether to take a genetic test or whether to screen. So they have to be.
Yes, what I actually see is, I'm not a person who got involved with, O-level and A-level syllabi. I think O-level and A-level syllabi have actually given, are not giving the correct message to our, younger generations.
Yes, sir.
A lot of negativities are portrayed in genetics and genomics and so on. So therefore, we have to look at, the positivities of genetics and genomics being, taught in A levels and O levels. So that is something that I plan to advocate more and more in the future.
Thank you, sir.
There are a couple of more questions, I think, on the chat. Is it possible to bring any special skills to a man from his older generation? I mean, maybe what your meaning is, can you pass skills? So this is the, moving on to the eugenics kind of thing. Obviously, I mean, based on our genetic makeup, we will be, there may be special skills that we acquire. So for example, we know, if you have, if you look at your musculoskeletal system, if your muscle, if you have what we call slow twitch fibers and fast twitch type fibers, depending on the fiber type that you have, you may be better at sprint events or endurance events. So that's something that's been seen in the field of athletics. Okay, so definitely. So there may be different types of things that you are able to do based on the genetic, your genetic makeup. So for example, take, for example, Muralidharan, right? He had a little bit of a bend in his arm. Obviously, that would have been caused by a genetic variation. And it gave him a particular, probably gave him a particular advantage in spinning the, spinning the leather ball. So that, so you get certain advantages. So height advantage sometimes, or flexibility. All of those comes because of genetic variants that people have. And of course, there is, that would be the nature, the background of nature coming in, of course, but of course, nurture also plays a big role, as it were, so therefore, we need to look at both sides. It's just not the nature, the genes alone, but the nurture as well as the other factors working. Another question, are these genetic testing and sequencing affordable in general for all to get benefit of the expected use? they are becoming more and more affordable. So for example, now we can sequence a person in our lab in the faculty for 95,000 rupees. So, and so if you really look at the costs involved in treatment for conditions like cancer and so on, it is, you might as well do the test and find out your predisposition, because the treatments are much more expensive. Again, when you look at, for example, treatments for cancer, with a 6,000 rupee test, if you can find out whether a particular drug works for you or not, and if you don't find out whether it works for you or not, and if you if let's say you have a genetic variant which makes a drug ineffective for you, then you may be spending about 2,000. You may be spending about 2 million rupees on a course of treatment that doesn't work for you because you didn't do the test, which was costing only 6,000 rupees. So it is always a trade-off between the cost of not only doing the test, but of the treatments and the other investigations that you will have to undergo in the absence of the test and so on. So therefore, we need to look at the entire picture and make a decision. And of course, some of the insurance schemes also pay for these tests now. Okay. All right. Any other questions?
Yeah, so Professor, I would like to ask a very general question from a layperson's point of view. These days, maybe, I would be wrong without quoting or substantiating my claims based on statistics. These days, I witness autism, the poor eyesight in children, and obesity at a very early age. And of course, we know these, could have been caused by the external environment, the adversities of, the food and other things like one of the participants asked, the Wi-Fi and other radiations might have caused. At the same time, I'm wondering what is the significance of, it might sound a little bit cruel, but what is the significance of natural selection? The medical science, maybe on the negative note would not allow the natural selection to happen. So we don't see all these anomalies or abnormalities in animal kingdom, whereas we encounter so much of adversities in genome in human race. So if this is going on, the selection of a stronger gene would not be allowed or permitted, so that the upcoming generations, the progenies, would be weaker and weaker in terms of facing off these the viral infection or any other kind of adversities. So I'm wondering, yeah. Thank you, sir.
Yes. Yeah. So there are complex genetic explanations for some of these things, and in a general lecture like this, I wouldn't want to embark on them. But let me give you some ideas on this, because these are very important. I'm trying to simplify some of the genetic observations that are coming from genetic research and so on. Let me see whether it comes out right. So one of the things that we see now is that, in conditions like autism and those others, it is not just one genetic change that is contributing to this. It is the burden of now if we take a look at all of us, now we have all of us here in this webinar today, we are 99.9% genetically equal. Whether whatever race, religion, country, whatever we are from, we are 99.9% equal. We are only 0.1% different. And that 0.1% amounts to 3 million differences amongst us. So some of these differences are disease causing, others are not disease causing, others may be disease causing, but not so strongly disease causing. So when you take a person, we cannot, so those strongly disease causing ones will not will manifest if we have them. The not so strong disease causing ones may manifest depending on what the interaction it has with other variants that we have. And of course, the interaction with the environment and so on, right? So today, because of all these environmental influences, while the sperms and ova are undergoing cell division in our bodies, they acquire genetic changes. And so when it goes to the next generation, the burden of these or the number of these bad variants are found to be more than what we had. And as a result of that, as you said, the future generations are, maybe not so as strong as what we were, or or even our parents were. And as a result of that, we find that the conditions, things like the intellectual disabilities, the other commoner conditions are becoming more and more. So that could be the explanation for it. It's a complex explanation. It is not something that we can really bring to a clinical practice and give guidance or treatment for patients as of now. But we are working, or the researchers are working on this in a concept called polygenic risk scores. And in the future, these may come into the clinical practice. So I hope I was able to make a complex, genetic thing reasonably understandable. And I hope that was clear.
Yes, sir. Thank you so much. Although I would like to ask you about although the scientists have dejected Lamarck's theory on genetics, but these days it seems like, it's being whatever is honed or developed would be passed down to generations. So is it still holding true, or is it just general belief?
If there's a genetic variant in your sperms, or the cells which produce your sperms or the ova, then it can pass down to the future generations. And of course, you would appreciate that it is more likely to happen in the male than in the female, because in the female, all the ova which go to produce the baby was went into cell division many years ago when they were in their mother's womb, and they get arrested in a particular point. However, in the males, even today in a male, their cells are dividing in the testis and producing the sperms, and as a result of that, with the exposures from the environment, those sperms will acquire more and more genetic variants. If they do, then so that is why males should stop smoking, stop taking alcohol, go to a healthy lifestyle. We see the male contribution to these conditions becoming more and more, especially things like intellectual disability and so on. I tell my medical students when I teach them in the first year, I ask them what is the best time they should get married. And I, jokingly tell them they should get married while in the medical faculty. But it's not, have their children while they're in their medical school without waiting till they become and get their, become consultants in their 40s. Nowadays, the age is becoming longer and longer. So,
yeah. Thank you, sir.
Okay.
Actually, I want to ask one question. Because of the, is it possible to give your consent to public this video to release this video to public?
Okay,
Sir?
I don't mind
Yeah.
today's lecture being released. No problem. We have that's
Yes,
fine.
we will put, yes. So we will release through our library YouTube. Okay, thank you, sir.
That's fine.
Yes. So including Q&A session.
Okay.
Yeah.
And there's another question. Even though some people have disease genes from birth, they do not show symptoms until a certain age. Why does that happen? Well, that is because there are certain genetic variants. They are very strong, and they will express at birth. There are certain genetic variants which are not so strong. They will express later on. Then, of course, there will be also the effects of other genes that will modify the expression of that gene. So there are various explanations like that as to why a particular manifestation of the condition will take time. Okay.